Hello, everyone, and welcome to the healthcare keynote for the Michigan Gun Violence Prevention Summit. Lisa Geller and I will be emceeing this healthcare keynote. Here we go. So I'm going to start just by walking you through, Lisa, next slide, the agenda for this healthcare keynote. We are going to feature several speakers. We're going to feature Dr. Natasha Bagdasarian, who's the Chief Medical Executive for the state of Michigan, Dr. Patrick Carter, and my cat, apparently, Dr. Patrick Carter, who is the co-director of the Institute for Firearm Injury Prevention for the University of Michigan, Dr. Brian Stork, the clinical researcher for SafERteens, Lisa Geller, the Senior Advisor for Implementation at Johns Hopkins University Center for Gun Violence Solutions, my cat, Seamus, who loves a good webinar, and myself, April Zeoli. I am the Director of the Policy Core for the Institute for Firearm Injury Prevention at the University of Michigan. And this exciting lineup of speakers is going to talk about the new legislation that was passed in the state of Michigan last year, going to talk about lessons we can learn from motor vehicle accident fatality reduction for safe gun storage. We're going to talk about best practices for healthcare providers and unique considerations for healthcare providers across the state. Hopefully there will be time for a robust Q&A. Next slide, Lisa. And after this, from 2 to 3:15 today, we will have 5 different breakout sessions. So you have to choose, but all are being recorded. Where we have a breakout session for people in emergency medicine, people in mental health care, primary care, hospital injury prevention specialists, and in public health. Next slide, Lisa. So I'm going to start with talking about extreme risk protection orders. Michigan did pass an extreme risk protection order law last year, and this law goes into effect on February 13. What it does is create a civil court order, so not a criminal action. This is a civil court order that temporarily suspends the right to purchase and possess guns by those who are high risk or at imminent risk of gun violence. And that can be suicide, self-harm risk, or risk of gun violence to others. Risk is determined by the behaviors that a person engages in. So maybe they're making threats, maybe they've aimed a gun at somebody, maybe you find a suicide plan or note that someone has written. Extreme risk protection orders are designed to prevent that fatal violence or gun violence, non-fatal gun violence, before it occurs. 2 states had these laws before 2015, Connecticut and Indiana. So there's not a whole lot of research on these laws yet. What research has been done has found that they're associated with decreases in firearm suicides when a state has the law. And there are also a couple of studies that looked at respondents, so people who were under the ERPOs, and looked at whether they died after they were under the ERPOs and looked at the cause of death. Did they die of suicide? Did they die of firearm suicide? Other means? What happened? And they compared those percentages and rates to that of the general population in their state. And it found that ERPO respondents had fewer firearm deaths than was expected given the state they were in. And the ERPO process is relatively straightforward. First, there's an application or a petition. That's the little pen in the triangle. And healthcare providers can petition when they view a client as being in imminent risk of harming themselves or others. The petition goes to the court. On the petition, healthcare providers, law enforcement officers, family members will write what behaviors that person is engaging in that indicates they are at risk. The court will view the evidence in the petition, any other evidentiary material that is given, and decide whether it meets the criteria set forth in the statute. If it does, they will issue the extreme risk protection order, which means, again, that somebody can't purchase a gun, and any guns that they already have will be removed or they will relinquish them to law enforcement. Let's go to the next slide, Lisa. And then we have domestic violence misdemeanor firearm restrictions. Michigan passed these last fall. And what it does, it says that if you've been convicted of a misdemeanor domestic violence crime, you can't have a gun right now. You can't purchase, you can't possess. Now, Michigan has a list of crimes that would qualify, and you need to have perpetrated them against a current or former intimate partner to be under this firearm restriction. And the restriction lasts 8 years after you've finished the penalties of that conviction. So after you've finished your jail time or probation or parole. We have some evidence regarding this law as well. The federal government has a similar law. The exception is that it's a lifetime ban, and it's narrower than the Michigan law and what crimes it covers. And that's associated with a 9% decrease in intimate partner homicide and a 31% decrease in the domestic homicides of male children. We also can look to research looking at other states with these laws. And when a state has this law, but also includes a relinquishment provision. So part of the law says that the court is authorized to tell the person that they have to give up their guns. They have to relinquish them. They have to return them to law enforcement for these 8 years, I guess, in Michigan. That is associated with decreases in homicides of pregnant and postpartum women. And most homicides of pregnant and postpartum women are intimate partner homicides. I'm going to let Lisa walk you through the last two laws.
Thank you, April. And I apologize if the screen share is weird because it wanted me to do presenter view where you'd only see half the slides. So I'm just going to do it in this way. The last two laws that April and I want to talk about are universal background checks and safe storage. Again, two other laws that you now have in the great state of Michigan and can think about how to implement these in the communities and the populations that you work in. So to start with universal background checks, when I talk about universal background checks, I really talk about them as the foundation upon which all other gun violence prevention policies are built. It really is critical to have this in place, and then you can go further and have firearm purchaser licensing to further enhance universal background checks. But without universal background checks, it's very difficult, again, to prevent people with histories of domestic violence who shouldn't have firearms, or of course, youth, minors, other folks that should not be able to access firearms. So in Michigan, HB 4138 and 4142 expanded background checks to all firearms. When we look at the states with the universal background checks, the number can vary based on what you're looking at, but essentially the number I pulled from Giffords, who I believe has a great tracker of state laws, is that 16 states and the District of Columbia have expanded background checks to all firearms, meaning that private gun sales, transfers, again, would have to go through a background check, not just purchases through a federally licensed firearms dealer. The evidence behind this is, pretty strong, particularly when we're looking at support of universal background checks. We have a lot of polling from Hopkins, from other institutions, showing that the vast majority of folks in this country support universal background checks. Upwards of 90% of people support universal background checks. Again, there's a foundation upon which all gun policies are built, and would close those loopholes that would allow a prohibited purchaser to buy guns from a private seller. We've seen this time and time again, particularly with these high-profile, high lethality mass shootings, that an individual who may have otherwise been prohibited was able to get a gun through a private sale or another transfer of firearms where they didn't need to go through a background check or perhaps a gun show. You've heard of the gun show loophole. It's a similar aspect of the system where if the background check doesn't apply to all gun sales, there may be certain ways for folks to bypass the federally licensed firearms dealer and the background check through that system and otherwise acquire a firearm and unfortunately do a lot of harm. So lastly, before we turn it over to our amazing panel, I want to talk about SB 79, 80, 81, and 82, which all relate to safe and secure firearm storage. Again, here we have evidence that this policy works, particularly when we're talking about reductions in youth firearm suicide. And we know that safe and secure storage laws can help prevent unintentional gun injuries, homicides, and mass shootings. We also know that, unfortunately, according to recent polling data that we have, that more than half of gun owners in this country do not practice safe and secure firearm storage, which means that they don't have a firearm unloaded, they don't secure it with a gun lock or other safe storage devices. So SB 79 here would require gun owners to store firearms unloaded and locked with a locking device or a locked box if a minor is on the premise. It also requires DHHS to have information to the public about the penalties for violating this law. It's important to note here, and when we're talking about clinicians, the role that a clinician could play here, of course, is educating about the importance of safe and secure firearm storage. But I also want to note that a lot of storage devices are very inexpensive. Gun locks, some gun safes can be under $50. Some gun locks can be given out free through certain programs in your state. I know a lot of states have storage programs where they will hand out gun locks for free or for folks who meet an income threshold. So this should not hopefully be a barrier for folks. If you're going to have a firearm, which are oftentimes very expensive, it is critical that firearms are stored safely to prevent access, particularly among youth. We also know that the majority of school shooters or minors who carry out acts of gun violence get their gun in the home. And so again, safely securing firearms, ensuring that those adolescents don't have access is important, can save lives, and also saves lives when we're talking about youth firearm suicide. So we have a lot more to cover in this healthcare keynote. April and my email are up on this slide here. We're going to turn it over to Dr. Bagdasarian to give a wonderful presentation, and then you'll hear from the rest of our panel. So I will stop my screen share now so that she can begin.
Hi, everyone. Sorry, having a hard time getting myself off mute. That was great information. And hopefully I can provide some information that is almost as good. I'm going to share my slides. Sorry, train going by. I'm going to share my slides here. And there we go. Okay. So I'll start out with just a little bit of data. This is Michigan data compared to the US, just showing that firearm deaths are increasing, and we are now above the national average in terms of firearm deaths per capita. So I'm sure you're all familiar with this and this slide as well, that shows that firearms in 2020 became the #1 cause of death for children in Michigan and across the US. This is very similar to a slide in the New England Journal of Medicine. This is the Michigan specific data. And the reason I'm showing this, even though I'm sure you're all familiar with this information, is number one, it's absolutely heartbreaking that firearm deaths now kill more children in Michigan than things like childhood cancers, drownings, and motor vehicle accidents. But when I look at this data, of course, I look at the firearm death line here in orange, but I also look at the line in blue, which is the motor vehicle accident death rate. And how did we bring that down? And so in preparation for this talk today, I did a little bit of a deep dive on what our public health approach was for motor vehicle accidents, because I advocate for a public health approach to firearm deaths. And I think it's important for us to realize what has worked for other things in the past. So this is a graph that looks at motor vehicle fatalities. So this is per 10,000 registered vehicles. This is not just for children. This is across the board. And what interventions were put in place when. So the data starts in 1940 and goes until 2022. So you can see the first statewide speed limit in Michigan was in 1956. Then in the 1960s, we had the first Michigan drunk driving law. In 1968, there was a federal law requiring new cars to have seat belts. In 1982, there was a Michigan law that required child seats. Then in 1985, a seat belt mandate. And in 2003, the blood alcohol limit was lowered. But I want to focus on the non-legislative fixes. So in the 1970s, airbags became mainstream and car seats were introduced. But here's the big one. In 1983, car companies pushed for seatbelt laws. And this was across the 50 states. Car companies were pushing for state seatbelt laws. And I thought this was really fascinating, and I wondered why. And I also want to point out that across the decades, there have been mass media and informational campaigns, policy enforcements, and vehicles have become safer. But I was really intrigued by this 1983 input by the car company lobbyists for state seatbelt laws. And I found an article from the Washington Post from 1984. And in 1984, the Transportation Secretary, Elizabeth Dole, said the government would require car manufacturers to start equipping cars with passive restraints, meaning airbags, she would suspend that rule if states with 2/3 of the US population enacted seatbelt laws. So the car companies were really anti-airbag at this point. So they said that airbags were very expensive and weren't effective without a lap belt anyway. At that point, Mercedes-Benz was saying airbags on the driver's side were $880, a lot of money back in 1984. And so GM and Ford supported state seatbelt laws. And that's the reason why we got our state seatbelt laws. After state seatbelt laws were enacted, seatbelt use went up drastically. So the graph doesn't go back very far, but in the 1940s, seatbelt use was at around 20%. So only about 20% of folks were voluntarily using seatbelts. They weren't available most of the time anyway. And by 2020, seatbelt use had gone up to 90%. So when I talk about a public health approach to gun violence, this is the type of approach I'm talking about. How can we get this recognized as a true health issue? And how do we bring more folks invested in solving this issue? How do we bring more folks on board? And I wanted to specifically talk about this public health approach. Let's get everyone on board together, maybe some unlikely bedfellows. And I thought, how does this apply with our new gun violence laws, specifically the safe storage legislation that was passed last year and that will go into effect in March of this year? Now, there was a recent MMWR that was published on unintentional firearm deaths, and specifically in children. So we know that safe storage is one big way that we would prevent these unintentional firearm deaths. And when we look at the circumstances, so this was a national study that looked at about 1,200 unintentional firearm deaths and the circumstances around them. So playing with a firearm, showing the firearm to others, that was a precipitating circumstance across all age groups. Unintentionally pull the trigger. Again, that was a leading situation across all age groups. Thought the firearm was unloaded, the safety was engaged, or the magazine was disengaged. That was primarily in kids over the age of 11, so the 11 to 17-year-old. And then firearm mistaken for a toy. That was in those younger age groups, 10 and under. I don't normally get emotional when I'm looking at scientific data, but this made me really emotional. What can we do to prevent these types of situations? They also looked at where the firearms were located. So the vast majority of these were loaded and unsecured. And the leading locations were inside or on top of nightstand, under a mattress, pillow, or on top of the bed, or on the top shelf of a closet. Again, just heartbreaking data. So when I talk about gun violence being a public health issue, I'm really glad that we've got some legislation passed. I think legislation is a core way to tackle this problem. But under legislation, we need to make sure we've got implementation, so we know how to actually implement safe storage, for example. That means telling our patients and our community members about resources. The last presenters mentioned gun locks and other options for safe storage. So how do we put those resources in folks' hands? We've got legislation. Now we need to make sure that there's local enforcement of that legislation and that communities are aware of this data, that we're speaking to community leaders. We're talking about this again as a health issue. I think we need to take this back as a health issue. And then we've also got the community awareness side of things. We need messages that resonate, and we need trusted messengers to speak about firearm deaths as a public health issue. And when we, as the Michigan Department of Health and Human Services, when we do focus groups, when we do surveys and polls, looking at who people still consider to be trusted messengers, healthcare providers lead that list. Doctors and nurses and other healthcare providers are at the top of that list. So that means talking about this issue as a health issue. I know that many folks already in their practice ask if folks have firearms at home, if their firearms are secured. But I think that this needs to be something that is a routine discussion, just like whether folks use seatbelts in cars, and a routine discussion for everyone, not just for our pediatric populations. So hoping that we can learn from not only mistakes of the past, but some successes of the past. Thanks so much, and I will hand over to the next presenter.
Just let me come up with my slides here. Okay, thank you so much, Dr. Bagdasarian, and to April and Lisa for their overview so far. I'm Pat Carter. I'm the co-director of the University of Michigan Institute for Firearm Injury Prevention. And I have the pleasure of talking to you a little bit about, what else we know works for firearm injury prevention in the clinical space. And I'll touch a little bit upon the new laws, but I'll build off of what April, Lisa, and Dr. Bagdasarian have already spoken to you about. You heard pretty eloquently from the prior speaker about how this is really an aspect of healthcare disease, and healthcare is really a window into what's going on in our communities. We are often the folks who first sound the alarm when we see new cases of new diseases, and we also have an opportunity to understand what's going on in our communities and then how to affect change. And there are, I like this picture at the right, there are multiple opportunities in the clinical space to help address prevention before people end up at the hospital with a devastating firearm injury or don't make it to the hospital with a firearm injury. And so part of what hopefully I'll be able to talk to you about with my portion of this keynote is about some of those opportunities for us as healthcare providers to intervene with our patient population. And as you heard also from the prior speakers, firearm injury is a medical disease. It's the same as all the other types of medical diseases that we see and treat. Everything from strokes and heart attacks to motor vehicle crash injury to diabetes and the complications of diabetes. And there are ways that we address prevention with our patients upstream of those. You heard a lot about with motor vehicle crash injury, how we had seatbelt laws that came into place and laws that governed training of new drivers with graduated driver's licensing. But we as healthcare providers had a space there for educating our patients about drinking and driving and educating our patients about wearing their seatbelts. And so we have that same role in firearm injury prevention. And the legislation that was recently passed really is provides us more tools in the case of extreme risk protection orders, but also more opportunities to provide that education, knowledge, and help to change behaviors to decrease risky outcomes. So, I usually try and start off with sort of what are the key messages that I hope people take away from what we're going to talk about. I think, recognizing the issue of firearm injury, Dr. Bagdasarian covered a lot about sort of the rise in firearm injury across Michigan, understanding those trends, understanding the opportunities for prevention in the clinical space. And, you heard a little bit about how physicians and other clinicians and nurses are seen still as sort of trusted members of society. But we do know for firearm injury prevention in particular that trust is enhanced by having some technical skills, understanding a little bit about the safety basics, and providing that counseling in a way that is informed to our patient population. So it's upon us to really develop the skills to provide that counseling and to identify the opportunities to do screening and counseling with our patients, both universal approaches to addressing issues around firearm safety, safe storage, and then selective and indicated approaches for high-risk populations around suicide prevention and interpersonal violence and intimate partner violence prevention. And I think one of the barriers we see in the data around why clinicians don't do a lot in this space is because they're not sure what to do with the answers. And that's again where training comes in, and having those skills both in counseling and counseling approaches, but also in really thinking about some knowledge base around firearms and firearm safety. And the big opportunities that I think exist in the clinical space for us as providers are thinking about ways of enhancing locked storage of firearms and providing counseling around safety, suicide prevention and lethal means counseling, and then violence prevention, both for youth violence and for intimate partner violence. I also think it's important to think about how we talk to our patients about this issue. And for a long time, I think the focus was really on the firearm itself, and not thinking more broadly about how do we focus on harm reduction and injury prevention. And I like the analogy with vehicles. Another one that I think is apropos is the analogy around pools. When we talk to patients around pool safety and keeping their kids safe from drowning, we don't talk to them about getting rid of their pool. We talk to them about putting a fence around their pool and providing swim lessons for their kids and flotation devices and having a parent or somebody there to watch the child while they're in the pool. So we figure out ways of talking to patients that align with their goals, in this case, having a pool, but also focus on risk and harm reduction. And that's the same approach that can be taken with firearm injury prevention. It's important as clinicians that we respect our patients' views, that we align with their values and focus really on how we keep them safe and reduce harm. And I think it's also important to recognize, similar to when we do counseling around substance use prevention or tobacco prevention or injury prevention in this case, that we think about how to tailor the recommendations and the discussion to the reasons why somebody engages in the behaviors they do, and also recognize that this is not a single discussion. This is not something that's going to occur once, that sometimes it takes multiple discussions over time to really achieve the optimal safety outcomes that we're trying to accomplish with our patients. And that doing these and having these discussions in a respectful way can move somebody step by step toward the safer situation and achieve those optimal outcomes that we're looking for. So on that front, really trying to get some training and skills around firearms and firearm safety, I think is really it's really critical. And we know that this is a deficit in medical training currently. I will just make a plug for the University of Michigan has developed some videos around safe storage and firearm safety and approaches to providing counseling in a clinical space. There are a number of other training resources out there that you'll have access to, but this one is local and was done by a number of the clinicians here. And so I think is an opportunity for clinicians that are on today's webinar that want to enhance their skills in this area. As you already heard, there are opportunities for improving lock storage and decreasing access to firearms. We know that the single greatest risk factor for firearm injuries, regardless of intent, is unsupervised firearm access among high-risk individuals during high-risk time periods. So the suicidal adolescent who has access to a firearm in the home, the young child who's playing at the grandparent's house where the firearm isn't stored safely, the cognitively impaired older adult who still has access to a firearm, the domestic violence abuser who has access to a firearm. So we know that that firearm access and availability is really a key risk factor. So one measure for some of these types of injury to reduce risk is really lock storage. And when we say that, we mean keeping the firearm locked, unloaded, and the ammunition stored and locked separately. And as you heard before, there are a number of different devices in that space. So trigger lock, clamshell lock, cable lock are one option that are relatively inexpensive. Gun safe or lock boxes are another option. The smart gun technology is coming, and there are opportunities there. And then ultimately taking apart firearms and making them not able to fire ammunition is another opportunity for changing the firearm availability in crisis moments. And we know that when clinicians provide lock storage counseling, that families are receptive to those discussions as long as it's done in a respectful way that honors their decision to own firearms, and that lock storage counseling can reduce fatality risk for multiple outcomes that you already heard from Lisa Geller. When clinicians provide counseling, it can be effective at increasing lock storage in households, and we know that that's done in a framework that really approaches it as patient-centered counseling, that doesn't just do simple public health messages or handouts, but really partners with the patients, understands why they have firearms, why they store firearms in certain ways, and really provides them with multiple safety options that enhances their autonomy to make decisions around safety for them and their family. There is stronger evidence. There's pretty strong evidence that such counseling, when it's paired with providing a locking device in the clinical scenario, does improve the likelihood that somebody will go home and lock their device up. And we need to be careful to make sure that we're matching the recommendations that we provide to patients to their motivations. Otherwise, it's likely to be a failure. And as I said earlier, multiple conversations over time are really optimal for achieving outcomes, as long as there isn't a situation with imminent risk. When I talk about multiple options, we think about things that can reduce access or availability during high-risk times. So lock storage is certainly one opportunity there. But among your cognitively impaired older adults, thinking about supervised access initially when they're in the early stages before things have gotten worse. Thinking about ways of reducing the lethality of firearms, so removing the firing pin or disabling the trigger mechanism are options. One option that I think is gaining a lot of traction in a lot of states is temporary removal or off-property storage. So thinking about other places where firearms can be stored during a moment of where somebody might be a risk themselves, or they might have somebody in the household who's a risk themselves. So thinking about shooting ranges or gun shops that might have storage facilities. For folks in the National Guard, thinking about storing in military armories, or temporarily transferring ownership to another family member through a legal process. And then ultimately, as we think about, especially among older adults, where we know suicide is such an issue, thinking about how do we counsel patients around, their plans for their firearms as they age, as their cognition changes, as they become less safe in handling them, and starting to have those conversations really early in our anticipatory guidance, so that they can really identify somebody who's a trusted family member who can identify when they're no longer safe with their firearms and help provide that support to transfer ownership or to reduce firearm risk. Also, another place where there's a fair amount of evidence currently for clinicians to act are really around lethal means access and counseling. So we know most suicidal crises are short-lived, and the method that somebody chooses in a moment of crisis really depends quite significantly on the availability of that method during a crisis. And we know that not all methods cause suicide fatalities equally. So firearms have a 90% likelihood of resulting in a fatal suicide, versus other means of suicide attempts where there's less likely to be a fatal outcome. And we also know that most survivors don't end up going on to die from suicide. So the idea of lethal means counseling is if we can reduce firearm access, reduce the access to this most lethal method during the high risk period, that most likely they will not end up being able to have a completed suicide. And even if they do attempt with another means, it's most likely to be a less lethal form of firearm attempt or form of attempt for suicide. So counseling in this area is really around how do we counsel families when they have an at-risk adolescent or an at-risk adult or an at-risk older adult to make that firearm inaccessible during that time period. And the idea here is again, to use the sort of patient-centered counseling, motivational interviewing approach, where we know especially in a recent randomized control trial, that this has efficacy in reducing firearm access among a high-risk population. And this can be a very effective means of counseling patients on aligning with their goals around firearms and temporarily decreasing their access during a high-risk period. In the interpersonal violence space, so we know that hospital emergency departments, primary care settings, trauma units are all really key places to intervene with at-risk populations, either youth who are engaged or involved in violence at the community level, or identifying patients who may be a victim of intimate partner violence, and that this can be a moment to intervene, link them to resources, provide safety planning, and to decrease the trajectory of their likelihood of a more violent or serious outcome, such as a firearm injury. We think about this a lot in sort of primary prevention, the things we can do to intervene upstream of a violent injury, to the things we can do in the secondary prevention space to prevent a recurrent violent injury, and also the things we can do to lessen the impact of outcomes that are associated with violence, including things like substance use disorders and post-traumatic stress disorder. And so I'm going to talk a little bit about two ways that we know are evidence-based to identify folks who are at risk. So one is a relatively new screening tool called the Safety Score, which was developed here in Michigan, actually using data from an emergency department, and is a screening tool to identify youth, especially who are at risk for firearm violence outcomes within the next 2 years. And this is a simple 4-item screening tool that can be asked of patients in an emergency department and a clinical care setting to identify that they may be at risk for either being the victim or the perpetrator of firearm violence within that next 2 years. And this screening tool is currently undergoing validation among 3 emergency departments and also in primary care. And so there'll be more information to come on it, but for folks who are interested in opportunities to add additional screening tools into their clinical space, here's an example of one. Another one that's been around for a longer period of time is something called the danger assessment. So with our IPV positive patients, assessing their risk for both firearm homicide or firearm homicide risk, lethal outcome, severe injury. This was a tool that was initially developed both to raise awareness with patients about the frequency and severity of their IPV, as well as to assess their risk and help guide safety planning. And there is a short version of the original 20-item tool that has been developed for clinical settings that you can see here helps to identify patients who may be at higher risk and need more intervention more imminent. We also have a number of programs that are either developed or being developed for the clinical space. One example is SafERteens that was developed here in Michigan, working with youth in an emergency department setting who have identified that they've been involved in fighting, and providing that type of motivational interviewing, counseling, and skills building around things like nonviolent conflict resolution, avoiding substance use, anger management. And this single intervention with a therapist social worker in the emergency department reduced violence outcomes for out to a year, and is considered best practice by the CDC currently for hospital care settings. And so a lot of the newer research is trying to build on programs like SafERteens and intervene in hospital settings with patients in an evidence-based way to reduce both their primary prevention risk as well as secondary prevention. So when we think about these new laws that that have come about, really, I hope to leave you with thinking about them as, you know, another tool in your arsenal, another tool in your toolbox for how to intervene with patients, in addition to all of the types of things that we've talked about so far. You heard about the safe storage laws and the opportunities as you're doing counseling with patients around locked storage to think about how to educate them about the new law and the requirements, so that both they avoid legal trouble, but also so that they enhance the safety within their own home. And it may be an important lever as you think about counseling around this issue. ERPOs are another tool, as you extreme risk protection orders, as you heard from April and Lisa earlier, to think about, especially for suicide prevention, but also for potential mass or school shooting threat, or in the case of violence against others. You know, it's an opportunity if the types of counseling that we talked about, lethal means counseling or violence prevention counseling, you know, is not effective at changing behaviors, or patients aren't receptive to that counseling, and you are concerned about the imminent risk of harm to the person or others, of thinking about how to file an ERPO and to intervene more imminently to prevent these severe outcomes and these devastating outcomes. And so it's really an opportunity to, as healthcare providers, make a real change on this issue in terms of using these new tools. And so that was actually what I was talking about this slide. So thinking about where those opportunities are in our clinical spaces to intervene and decrease the risk for these outcomes among our patients, our older adults who may be at risk of harm to themselves, you know, our patients who may, you know, we know, especially in school shootings, that there's a lot of leakage from the school shooter prior to the event, thinking about when, you know, we are engaged by families around how to intervene or how to help. You know, ERPOs are a tool that we can use in the clinical space for prevention. We are at the University of Michigan here developing and launching soon a toolkit that will have a lot of information on extreme risk protection orders as the state releases it and provides it to us. And you can see here that there's multiple opportunities for implementation and thinking about how these laws can be integrated into your practice. And so there's a whole section that will be there on healthcare workers and healthcare networks. And so as you work to get more education on this topic as a clinician, please do look to the University of Michigan for some of those resources. I know Johns Hopkins also has a toolkit in education, as well as there's another resource out there called the Bullet Points Project from University of California, Davis, that's also pretty good on providing both clinical scenarios and opportunities for prevention. And with that, I will turn it over, I believe, to Dr. Stork.
Good afternoon, everyone. Get set up here quickly and get going. Well, as Dr. Carter said, my name is Brian Stork, and I am a urologist in Muskegon, Michigan. And for the past couple of years, I have had the pleasure of working with Dr. Carter to implement an evidence-based youth violence prevention program called SafERteens into our community. And going from an academic idea to a real-world intervention is sometimes a bumpy road with lots of challenges and opportunities. And I was watching the game last night, as I'm sure many of you were. I experienced some frustration, some disappointment, but also quite a bit of pride in the team. And I thought maybe one way of understanding some of the challenges and opportunities of implementing any kind of education program in a healthcare setting can be better understood through a playbook or a series of football plays. So just for background, I grew up in a small rural community in Iowa. And one of the opportunities that we had to get off the farm and ultimately to get off of the county and the location that we were in was to play football. And I had the opportunity to play against a great coach named Ed Thomas. Ed coached for a number of years. He had 2 state championships. He sent 4 players to the NFL, including Detroit Lions defensive end Jared DeFries, who spent his entire career in Detroit. And sadly, in 2005, Coach Thomas was shot in the weight room in front of his entire football team by a former player with a handgun. And so this issue has been on my mind for quite a while, as you might imagine. So I moved to Muskegon in 2002, and in 2015, we started to see a significant uptick in violence in our community. So much so that opposing teams decided that they weren't going to come to one of our local schools, Muskegon Heights, over fear of violence and gun violence injuries. And so that harkened back to the experience that I had had in Iowa, where young men develop discipline and character, determination, and all sorts of great qualities through football. So I couldn't kind of, in good conscience, continue to watch this happen. So we did a study here in Muskegon. We did a retrospective study over a 4-year period from 2015 to 2019. And what we found that in our community, in our hospital, 85% of the time we're treating young African-American men. And so not only is there an inequity in the victimization of young men in our neighborhoods, it's happening frequently, and it's costing us a lot of money as a society. We calculated during that 4-year period that Medicaid spent approximately $5 million treating gun violence injuries here in Michigan. So after our paper was completed, I thought that I'd be getting a phone call from the insurance companies or from our CEO, asking us about what we could do together to stop the gun violence in our community. And much to my surprise, the phone didn't ring. It was crickets. And it was crickets for a while until I got a phone call from Trinity Health Muskegon's injury prevention coordinator, Holly Alway. To be honest, I didn't even know injury prevention coordinators exist. And I think it may have to do with the fact that they spend a lot of time in the community working on some of the topics that were discussed this morning: car seats, swimming lessons and swim safety, burn prevention, and those types of public health things. And so Holly was really interested in partnering with myself, our team, and our entire community to really see if we could bring a prevention program into our community. And as luck would have it, we really stumbled across a Hall of Famer in that we were able to get Dr. Patrick Carter to work with us, to get to know us, to trust us, one would argue to adopt us, and help us start to get funding for the implementation of this evidence-based youth violence prevention program called SafERteens. I'm not going to go into what SafERteens is in a lot of detail, but I can explain to you some of the barriers that we've had in implementing it and how they apply to how we may have barriers in implementing safe storage in ERPO education and healthcare. So when we got hooked up with Dr. Carter, I was really excited because at the same time, Northwell, specifically the CEO, Michael Dowling, was really making a lot of press. He was talking about gun safety. He was talking about violence prevention. He had over 1,000 hospitals signed up to make this a priority, gun safety a priority. And I thought, well, geez, this is going to be easy, right? We're just going to run this ball right down the middle. I'm going to have my CEO, my other physicians, the nurses, and we're going to implement this program, and it's going to be great. How hard can it be? Well, it turns out it can be really hard. There were some unforeseen barriers that I didn't expect. I didn't expect after COVID that the hospitals would be struggling financially. I didn't expect the impact that the mergers of all of these hospitals would have on the administration's ability to consider programs like this. In fact, I didn't even consider the fact that many CEOs now are sort of often buildings not attached to the hospital and oftentimes behind closed doors. Currently there's a problem with nursing burnout. I think, as many of you know, we found out that there's too few social workers in the state of Michigan. Specifically in our emergency room, we're short social workers. And it doesn't look like any of these problems are going away anytime soon. So, you know, in life you get knocked down, and that's one of the lessons that football teaches you. But, you know, as urologists, we have a certain perspective on life. We may not always know where we're going, but we sure know where we've been. And that adds to a certain amount of resiliency. And as the coach said, you know, we need to push a little harder. We need to be a little stronger. We need to think a little harder, and we need to get after it. So we got after it. And in order to get after it, we really had to change our offense. You know, I couldn't be doing this practicing full-time across the street. I needed somebody in the hospital to be a quarterback and to run this new offense. So thank goodness I was able to come across a man named Justin Dirks. Justin is a performance excellent consultant at Trinity Health Muskegon. I didn't know these people existed either, but basically Justin uses lean processes and other process improvement tools to help implement processes in the emergency room. And he was kind enough to join our team. And I can tell you that everything changed when we got this quarterback, when Justin joined our team, because Justin was a natural leader. He was trusted by the staff. He was focused on processes, and he was focused on results. You know, we thought when we implemented this program that it was going to be nurses doing the screening and social workers delivering the intervention. And what we found, as I pointed out earlier, is that there were some significant barriers to that. The nurses were busy and we didn't have enough social workers. So it turns out there's other people in the hospital that have bandwidth. For example, on the left here is a woman named Iris Towers. Iris is in charge of registration in the emergency room. She has 40 employees under her command, if you will. And a lot of them live in the neighborhoods that are most affected by gun violence. On the right-hand side, we have one of our hospital chaplains. Turns out delivering educational materials or an intervention is right up the chaplain's alley. And the chaplains have some bandwidth to be able to do this, at least in our institution. But we needed more, you know, even the registration and chaplains are stressed. So I learned about community health workers as I continued to implement this program. And community health workers are a very reasonable, cost-effective way to deliver educational materials. What I didn't expect, however, is that I was going to have to fundraise myself to obtain a community health worker for the hospital. That's how stressed the hospital resources are right now. So we've been able to, one small check at a time, work our way towards getting a full-time community health worker to start delivering interventions and really help run our program. As I mentioned, community health workers really are embedded in the community and do a lot of things other than violence prevention. But, you know, my team extends here beyond Muskegon and beyond the University of Michigan. The Michigan State Medical Society was part of the team, part of End Gun Violence Michigan that lobbied for these bills. I testified personally a couple of times. Rebecca Blake here to my left has been in charge of continuing education for the society in the past. A lot of our physicians turned to continuing education through the society, and the society has a great way to distribute that and create it when necessary. And so here are my colleagues here on the right-hand side, the board of the Medical Society, lobbying some of our state representatives. And then, you know, our team extends even beyond Michigan, right? So I didn't speak a whole lot about the implementation of ERPO in this talk, but I suspect ERPO education is going to be a lot like the education for safe storage and the implementation of SafERteens. And Lisa she's an all-star. We're glad to have her on our team, and I feel personally honored to know her. So, as Coach Campbell said, he's unbelievably proud of everybody, as am I on this team. It takes a team at all levels to be able to pull this off. And I hope that my presentation today helped you think about some of the barriers and how they may be overcome as we move forward together. Thank you for your time and attention.
Thank you so much, Dr. Stork, Bagdasarian, and Carter, and Lisa for her part of our joint presentation. We're going to do some questions now. Please remember to, chat is disabled. That is why you cannot post questions in the chat, and we cannot see questions posted in the chat. However, some questions have gotten to us other ways, people who know how to text us. So my first question is for Dr. Carter. So Dr. Stork brought up a number of barriers to clinical interventions for firearm injury prevention in his presentation. I'm curious, where do you see that there are opportunities for firearm injury prevention work, and what will it take to support practice integration?
Yeah, that's a great question. So, I think there are barriers, and I think especially in the sort of post-COVID world that we live in now, healthcare has changed so much. I think, we do have to recognize those barriers, but I think, I think the biggest thing is for clinicians to be champions. Dr. Stork is really a champion for the practice integration of SafERteens within the community in Muskegon, and I think, somebody who has that persistence, and I think is a champion within their own healthcare system and healthcare setting, I think is really a key part of the puzzle. So hopefully that's one aspect of what we leave you with. I think the other is, and what you heard as threads and what Dr. Stork talked about is really, flexible thinking about how to think about integrating this. How do we use the whole healthcare team to help support integration of these types of clinical interventions? We have trust with our patient population, and some things will probably need to be done one-on-one with the patients that have had a long-term clinical relationship with primary care providers. But other types of interventions that may be more immediate, that may be more intensive, such as the SafERteens intervention, we can start to think about how we can extend delivery by using other members of the team or community health workers, as is being done with the SafERteens program in Muskegon, and think really flexibly and creatively around that to help advance.
Thank you so much. Dr. Bagdasarian, you gave a great presentation, and I loved all the comparisons to other public health crises, because I think that's a really compelling way to show that this should not be treated differently just because we're talking about firearms. But can you tell us a little bit about how your position and how the state can support physicians' use of all of the laws that we've mentioned today?
So number one, I think that at the state level, we can be conveners for some of these discussions to happen. But we can also be a resource for how to access some of these tools. So we know that there are organizations around the state that have gun locks and that will give gun locks away for free. And we can work with you on making some of those resources available to clinicians in their communities, because I also think every community has slightly different needs, and there's no one size fits all. But I also think that we can be a leader in terms of talking about this issue. For so long, healthcare and public health didn't, because we couldn't talk about firearm deaths as a public health issue. And I think we're finally at a stage where there is political momentum and we can talk about these issues. We have a governor who's extremely supportive. So we are happy at the state level to sort of lead the charge in talking about this as a health issue, maybe helping connect you all with resources that you can distribute in your communities. We also can and have been partnering with Michigan State Police and working with law enforcement for gun take back events and things like that. So whatever I can do to support you, please feel free to ping me and let me know.
Thank you. Question for Dr. Stork as well. We know that funding is a barrier in public health. It always is. It always has been. What are your thoughts on how we can have more sustainable funding for the work that you're doing and the other physicians on this call are doing as well?
Well, that's a great question. Thank you, Lisa. You know, when we started working with Dr. Carter, we were able to get a grant through the Centers for Disease Control, which went into an organization called the Michigan Youth Violence Prevention Center. And that grant was to help with research and implementation. But the CDC expects communities to participate. They expect communities to have skin in the game, if you will. Well, our community doesn't have a lot of skin to put in the game, if you will. You know, one of the reasons that we have such high rates of violence has to do with the socioeconomic situation in which our community currently exists. So I'm a urologist. I now spend a lot of my time writing grants when I really should be seeing urology problems. I think if we were able to work with our legislators to get funding that was predictable and sustained for community violence intervention programs, that would be a real win for everyone involved.
I also think critical to that discussion is, reimbursement for the delivery of clinical services. So we know there are states out there, California is an example, where delivery of counseling around firearm safety and violence reduction is reimbursed. And there's a lot of challenges in the current reimbursement codes for that in terms of who has to deliver the intervention and how much time, and whether it has to be done in person or can be done via telehealth. And so some of those represent barriers that, if we think about how to increase integration of these types of interventions within clinical practice and have healthcare systems deliver these types of interventions, that's another lever that we need to think about both at the state and the federal level.
Thank you, Dr. Carter. It looks like someone has raised a hand. Not sure if Philip is able to ask a question, if Philip has a question, but we do have a few minutes. Otherwise, we want to replug the breakouts. Okay, Phil, it looks like Philip's here. Do you have a question for our panel? Okay, perhaps
Lisa,
that was...
I do have a comment.
Oh yes, please, Dr. Stork.
You know, what I've learned in my experience is that a lot of these programs, when you go into a healthcare setting, are bottom up, meaning there's someone that's been affected by violence who wants to facilitate a change. And it's almost as if you're swimming upriver. And so particularly for our colleagues that aren't physicians, they really need physicians to partner with them and to advocate and be champions for them if we're going to make any change. In a perfect world, it would be the CEO that was driving everything from top down. But as I presented, there's a lot of challenges that they're facing right now. And so as we work top down and bottom up, physicians just have to be there to support their colleagues.
Great point, and a good place to end potentially on that point. So I'm going to put in the chat the breakouts again. Those are from 2 to 3:15 today. So you'll have a little bit of a break between now and then. And you can hear from this wonderful panel again in some more of an intimate conversation, a smaller group potentially, and hopefully the chat will be working so we can get some more Q&A for those breakout sessions as well. Any final comments from the panel? Okay. Thank you all. We'll end about 10 minutes early.